The legislative hearing of the Subcommittee on Health will now come to order. I want to welcome all members of the subcommittee and our witnesses. It's a pleasure and a privilege to collaborate once more on crucial matters affecting our veterans. Today, we'll be discussing 12 bills, each aimed at improving various aspects and critical needs of veterans' whole health care. These bills range from increasing the availability of assistive mobility devices for veterans living with paralysis to guaranteeing appropriate compensation for providers of essential transportation services and other pressing concerns. I would like to discuss my bill, H.R. 3584, the Veterans Cannabis Analysis, Research, and Effectiveness, or CARE Act. For years, we've heard anecdotal, firsthand accounts from veterans who have experienced decreased PTSD symptoms and pain through medical cannabis. My bill would create a research framework for exploring the potential health benefits of cannabis for treating PTSD and chronic pain. Through rigorous research, the VHA can explore a new evidence-based treatment option that may have the potential to enhance the lives of those who have served our nation and to treat the invisible wounds of war. My bill also has a commitment to preserving data for future research, which underscores a long-term vision for evidence-based treatment options. It's important not to let old stigmas interfere with the healthcare treatment veterans are receiving if a therapy is proven to be safe, effective, and improve veterans' quality of life. I'm proud to introduce this bill so that we can gain insight into new therapies that could help those who need it most. Today, we'll also discuss Representative Van Orden's bill on alternative therapies. H.R. 7347 would direct the VA Secretary to report to Congress on whether VA will include emerging breakthrough therapy drugs in the VA's list of pharmaceuticals after FDA approval. I look forward to a productive discussion today on my legislation as well as the rest of the bills on today's agenda and the positive impact they promise. And thank you to our witnesses and those organizations that submitted statements for the record for their thoughtful feedback on my bill and the other bills we will discuss today. Ensuring the highest standard of care for our veterans is more than our responsibility. It's a profound honor. I look forward to our discussion on the merits and challenges of all the legislation before us today and the impact they could have on VA operations and, most importantly, on veterans' lives. And thank you again for all being here. Because of the interference with votes for our hearing today, we'll come back to Ranking Member Brownlee for her opening remarks. We have a full agenda today, so I'll be holding everyone to 3 minutes per bill to get through it in a timely manner. This morning, we are joined by several colleagues who are going to testify about their bills. We're extremely grateful for their work in serving our nation's veterans. With that, I ask unanimous consent that all non-committee members be waived on to speak on their bills from the dais. Hearing no objection, we will move forward. I now recognize Representative Bergman. You are now recognized for 3 minutes.
Thank you, Madam Chair. I would like to start by briefly mentioning 2 bills that the committee will discuss today. Congresswoman Dingell's VA Peer Review Neutrality Act, which I am proud to be the Republican co-lead for, and Congressman Van Orden's bill to require VA to make a formulary determination for psychedelic therapies within 6 months of FDA approval. Both are important pieces of legislation, and I look forward to hearing their sponsors' testimonies. I would also like to take a few seconds to show my appreciation for one of our witnesses in particular, Ms. Brittany Elliott, as well as her full-time caregiver and father, Morgan Elliott. I have had the opportunity to spend a wonderful amount of time with both of them, hear their story, and gain a sense of the difficulty that currently exists for our SCI/D veterans. We'll talk about that acronym later. Brittany is strong, determined, and undaunted by the bureaucracy she has been forced to deal with, and as a fellow Marine, I would expect nothing less. Welcome to both, and Brittany, I look forward to hearing your testimony. The Veterans Spinal Trauma Access to New Devices, or Veterans STAND Act, takes commensurate steps to improve care for veterans with spinal cord injuries or disorders and ensure they are assessed for and provided with assistive devices that they are already clinically eligible to receive. First, the bill would codify the requirement that VHA provides an annual spinal health assessment for SCD veterans and includes specific requirements for proactive outreach to those who are eligible. Secondly, the bill takes steps to ensure veterans are informed of and assessed for assistive technology that can help their independence and mobility. As many veterans will tell you, despite both of these measures already existing on paper at VA, the actual experience of SCID veterans has varied widely, and in many cases, VA has outright failed to meet their needs. This is why the bill also takes steps to improve transparency and accountability at VA, including by requiring the Secretary to submit reports to Congress on the extent to which veterans are actually being provided with these life-changing technologies. Finally, the bill would direct VHA to consult with veterans advocates, medical specialists, and device experts and manufacturers when developing clinical procedure guidelines for assistive devices, something that will only become more important as the rate of technological advancement continues to increase exponentially and new devices enter the marketplace. The fact is, we are systematically failing those veterans paralyzed from service by denying them simple and rapid access to essential assistive technology. Veterans like Brittany who have received these devices have often only been able to do so through extensive self-advocacy, months of delays, and hundreds of miles of travel to find a VA doctor and facility willing to meet their needs. I'm grateful to Chairman Boss, Subcommittee Ranking Member Brownlee, and Congresswoman Dingell for helping me introduce this bipartisan bill, as well as the other committee members who have joined as co-sponsors. I've also heard that Senators Moran and Tester, the ranking member and chairman of the Senate VA Committee, have introduced a Senate companion bill today. I wholeheartedly welcome any and all constructive input to make sure we advance the best possible bill to improve the lives of veterans with spinal cord injuries and disorders. However, as I hope you learned from Ms. Elliott's testimony, our current way of doing things is not working for many veterans with spinal cord injuries. That being is unacceptable, and Congress must act. I yield back.
Thank you. The chair now recognizes Ranking Member Brownlee for her opening statement.
Thank you, Madam Chair, and thank you for being patient with me being slightly late. But thank you very much for convening today's hearing. I look forward to our discussion of the 12 bills on today's agenda. I know many of the sponsors of legislation on today's agenda are planning to be here to present their bills, and I'm eager to hear from our witnesses, so I will aim to keep these remarks brief and highlight just a few of the bills. I'm pleased we are considering H.R. 6373, the Veteran Spinal Trauma Access to New Devices, or Veterans Stand Act. I'm proud to be co-leading this bill with Representative Bergman, Bost, and Dingell. H.R. 6373 will codify VA's existing policy of providing annual preventive health assessments for veterans with spinal cord injuries or diseases. These exams are vitally important because they can help identify and treat health issues before they become too serious. Secondly, our legislation aims to increase veterans' access to state-of-the-art assistive technology known as personal exoskeletons. Ms. Elliott, a veteran who is testifying on our second panel, has a great deal to share about her personal experience with this technology and her attempts to access it through the VA. We look forward to hearing from her. Advancements in technology can provide revolutionary options to help paralyzed veterans lead their lives to their fullest potential, and the Veterans Stand Act will help ensure VA remains at the forefront of innovation and medical treatment. I understand that VA has some concerns about the bill, but I hope the department will work with us to make those improvements. I'm also pleased that we are considering Representative Underwood's bill, H.R. 3303, the Maternal Health for Veterans Act. This legislation builds upon the Protecting Moms Who Served Act, also sponsored by Representative Underwood, which was enacted in 2021. In addition to codifying VA's maternity care coordination program, the Protecting Moms Who Served Act mandated a GAO report on maternal health outcomes among veterans. That report was issued in January of this year, and I ask unanimous consent to enter this report into the hearing record.
No objections.
GAO analyzed VA data on deaths and severe maternal morbidity among pregnant and postpartum veterans from fiscal years 2011 through 2020, the most recently available data. The findings are concerning. Among other things, GAO found that the severe maternal morbidity rate among veterans increased between 2011 and 2020, and this rate was highest among Black or African American veterans. H.R. 3303, the Maternal Health for Veterans Act, will require VA to report annually on activities related to maternity care coordination. These reports must include data on veterans' maternal health outcomes along with recommendations for improving them. Further, this bill authorizes funding through fiscal year 2028 for VA's maternity care coordination program. I'm pleased that Ms. Melissa Bryant of Minority Veterans of America is here today to testify on this legislation. As you will hear from her, there have been many positive outcomes of VA's maternity care coordination program since it was established in 2012, but there are still many areas for improvement. Just yesterday, I participated in a roundtable with Ms. Bryant and other women veterans where we discussed VA's implementation of the Deborah Sampson Act, which was signed into law just over 3 years ago. While the Deborah Sampson Act made significant improvements in the delivery of benefits and health care for women veterans, it's clear there's more work to do, and we need to continue advancing additional legislation like Ms. Underwood's bill. I understand Representative DeLuzio and Ms. Dingell will also be here. I see Ms. Dingell right here in support of their bills, H.R. 3225, the Build for Veterans Act, and H.R. 5794, the VA Peer Review Neutrality Act. I will defer to both of them to provide more detailed explanations of their bill, but I want to express my support for each, and I will yield there, Madam Chair.
Thank you very much, Ranking Member Brownlee. We're going to go back to presentation. I now recognize Representative DeLuzio for 3 minutes.
Thank you, Madam Chair, and thank you, Ranking Member Brownlee, for the kind words about my bill, the Build, Utilize, Invest, Learn, and Deliver for Veterans Act, the Build for Veterans Act. Common sense piece of legislation to modernize and streamline the delivery of VA medical facilities and other infrastructure projects, strengthen the workforce, save public money by expediting the disposal or repurposing of unused or vacant buildings that the VA owns. I think it's badly needed. We all know across the country in our districts, the VA opens lots of new or remodeled facilities every year, but the need for more modern facilities is much greater than its current operational tempo, budget, or frankly, infrastructure workforce. Those VA facilities are on average around 60 years old, and the VA has around $180 billion in backlogged infrastructure projects, a backlog that's growing faster than VA can address them. This bill continues to build off the historic infrastructure investments of Ranking Member Takano's PACT Act, and I'm proud to say there is a companion effort in the Senate led by Chairman Tester. Specifically, the Bill for Veterans Act works to tackle workforce issues, establishing a staffing model to ensure a base level of capital asset staffing, and through new recruitment and retention incentives. On infrastructure streamlining, the bill requires VA to implement a more concrete schedule to eliminate repurposed, unused, or vacant buildings, to ensure there is an adequate offices and staff to efficiently manage capital assets at all levels, and by implementing systems review the climate resilience of all capital assets. There's also an oversight section of the bill requiring VA to provide an annual budget for Congress to monitor plans of performance data over a 10-year period, requiring a submission of a strategic plan to improve VA's delivery and management of capital assets, and requiring the examination and reporting of VA-related capital asset improvement from the VA and its Inspector General. The bill is supported by many VSOs, including VFW, DAV, PVA, the Legion, IAVA. I think this is a good bill, one that I hope my colleagues will support. The Bill for Veterans Act strengthens VA's capacity to deliver veterans the state-of-the-art care that they all have earned and saves public money in the process. Madam Chair, I yield back. Thank you.
Thank you, Representative DeLuzio. I now recognize Representative Bost, Chairman Bost, for 3 minutes.
Thank you, Madam Chairman. I'm glad to be here today to speak on my bills, H.R. 5530 and VA Energy Transportation Access Act, and H.R. 6324, the fiscal year 2024 Veterans Affairs Majority Medical Facility Authorization Act. H.R. 5530, the VA Emergency Transportation Access Act, would help veterans keep access to emergency transportation services. I know firsthand that quick access to emergency transportation services can be the difference between life and death in rural and remote areas of this United States. My common sense bill would require VA to work with ground and air ambulance providers to develop a plan that protects and expands rural veterans' access to emergency service first. Right now, VA's proposed rule would slash reimbursement for good companies that provide vitally important ground and air emergency transportation services. VA plans reverts to the outdated medical reimbursement schedule that is based on data from 1998 and 2002. My bill would ensure that veterans, especially rural veterans, have access to transportation for timely medical care. And it would guarantee that transportation companies are reimbursed fairly for their services. My bill also would create a simple and sensible process for VA to make needed changes in reimbursements. This bill is about protecting our veterans so that they have access to care they need when they need it. Next, I would like to speak about Bill H.R. 6324, the fiscal year 2024 Veterans Affairs Major Medical Facilities Authorization Act. This bill would authorize over $4.6 billion in important major medical facilities projects that would modernize VA medical facilities across the country, building on the personal commitment to bring VA into my personal commitment to bring VA into the 21st century. This legislation would authorize a number of key construction projects across the country that we know VA medical facilities need. These projects range from the construction of new healthcare centers to the expansion of mental health facilities. My bill would allow VA to replace outdated community living centers and update existing facilities with the latest earthquake-resistant technology. By continuing to modernize VA facilities, we will ensure that the veterans have access to high-quality, modern medical care that they deserve. It is vitally important that we address critical construction projects in a timely and fiscally responsible manner. I look forward to ensuring my legislation does exactly that. Madam Chairman, I yield back.
Thank you, Mr. Bost. I was ready, willing, and able to yield you another 3 minutes, but you spoke on both H.R. 5530 and H.R. 6324. Thank you. I now recognize Representative Dingle for 3 minutes.
Thank you, Madam Chair. I want to start by thanking you and the ranking member for including H.R. 5794, the VA Peer Review Neutrality Act, as part of today's hearing. I'm leading this bill alongside my good friend and colleague from Michigan, Representative Jack Bergman, and I appreciate his support and partnership on this very important issue. I care deeply, like all of you do, about our nation's veterans. So when they come to me with problems, I listen. When I started hearing concerns from veterans and employees at the John D. Dingle VA Medical Center in Detroit, I knew these problems were serious and immediately started sounding the alarm. I personally went to the VA Secretary, the Veterans Affairs Secretary, and I want to thank him here for listening. These efforts led to a review by the VA Inspector General into allegations of misconduct at the Detroit VA Medical Center. Unfortunately, the review uncovered findings of misconduct and a pattern of substandard surgical care, which included the manipulation of external peer reviews. The top 3 administrative leaders at the facility have since been removed, and under new leadership, the VA has made progress in restoring trust and accountability. Still, it's critical we never allow this kind of misconduct to happen again at any VA hospital across the country, and a member of Congress should not have to go directly to the VA Secretary. With the VA Peer Neutrality Act, we can take concrete steps to strengthen accountability and neutrality within the VA's peer review process. This bill will codify a VA policy that ensures members of a VA facility's peer review committee cannot participate in peer reviews of cases they were involved in or cases that present a conflict of interest. Our veterans deserve the best care, and this legislation will better strengthen accountability and oversight within the VA medical facilities that serve them. I look forward to continuing to work with this subcommittee on this very important legislation, and I yield back, Madam Chair.
Thank you, Representative Dingle. The chair now recognizes Representative Van Orden for 3 minutes.
Thank you, Madam Chair. I'm a Navy veteran of 26 years and 22 of those were spent as a SEAL. My entire adult life has been spent operating next to some of the bravest men and women in the world, actually. And although most of us have survived combat, many of us come back home and we are unable to deal with the issues that presented us in that very difficult environment. To date, with the passing of Senior Chief Mike Day, I've had 21 of my friends commit suicide. We just had another Navy SEAL commit suicide 2 weeks ago. These things don't make the press, but we have a very tight-knit group of folks. And, his name will never be made public, I don't think. But so I didn't know him, but who did is his family and his teammates. And we don't forget our brothers and sisters who unfortunately make a permanent decision over a temporary problem. We've given the Veterans Administration $16.5 billion last year and $150 billion since 9/11 for veteran suicide, and the suicide rate continues to increase. We had Dr. Scavella here, who has an incredibly impressive academic record and an absolutely terrible practical record of preventing veterans from committing suicide, so we have to try something different. We simply do. We've got these incredibly brilliant scientists and doctors and all this stuff, and what they're doing is not working. And we know that because more veterans are committing suicide now than they have in the past. And so I've introduced H.R. 7347, and that's to make sure that we are able to mandate the Veterans Administration to report back to us within 180 days on its plans to incorporate psychedelics into treatments upon FDA approval. And I'll tell you what, honestly, I'm not 100% sold on this. I am not. But you know what? It works for some of our veterans. It does. Some of our veterans on this committee actually have done psychedelic treatment to prevent or to help them deal with PTS, and it worked for them. So we're going to be in all of the above if it's going to help a single veteran, even as a bridging mechanism from preventing themselves from committing suicide. I'm 100% sold on faith-based programs because they've proven to work also. And so I'm asking everybody, Ms. Brownlee and Madam Chair, I'm asking you all to vote for this, understanding that it's not a do-all, fix-all for everybody, but it's gonna help at least save one veteran's life so that I don't have to go to their funeral and get on my knees one more time and speak to these fatherless children and look at their widow and try to explain to them why we didn't do everything we possibly can to prevent their husband from committing suicide. So I'm imploring my colleagues to please vote this, get it through the subcommittee to the full committee to the House, and let's actually do what we say we're here to do, and that's to prevent veteran suicide. With that, I yield back, Madam Chair.
Thank you, Representative Van Orden. The chair now recognizes Representative Underwood for 3 minutes.
Thank you, Madam Chair. Thank you for inviting me to speak today and for considering my legislation, the Maternal Health for Veterans Act. While I currently sit on the House Appropriations Committee, I previously had the honor of serving on House Veterans Affairs in the 116th and 117th Congress, and I hope to be back next Congress. But serving veterans is one of the greatest privileges we have as members of Congress, and I am honored to serve veterans both on and off this committee. The United States is in the middle of a maternal health crisis that's getting worse, not better, and veteran moms are dying. America has the highest pregnancy-related mortality ratio of any high-income country and significant disparities in outcomes. To solve this crisis, I introduced the Momnibus, a set of 13 bills, including the Maternal Health for Veterans Act, that comprehensively address our nation's maternal mortality crisis. Last Congress, we had the first bill from the Momnibus enacted, the Protecting Moms Who Served Act, which invests in world-class care, maternity care for our veterans. I was so excited to go to the White House and see President Biden sign the Protecting Moms Who Served Act into law. But even then, I knew that the Protecting Moms Who Served Act was only the beginning. Now, earlier this year, the GAO released the report we commissioned in the Protecting Moms Who Served Act, and their findings were devastating, but not surprising. In less than 10 years, the number of veterans suffering severe pregnancy complications almost doubled. Pregnant veterans are more likely to have physical and mental health conditions that may lead to adverse maternal outcomes or complications. And for veterans, just like the general population, mental health conditions increase the risk of severe maternal health complications, including the risk of maternal death by suicide. We have a lot more work to do to live up to the promises we made to our veteran families. They served our country, and our job is to serve them. And that's why I introduced the Maternal Health for Veterans Act. This legislation builds on our success advocating for quality maternal health care for our veterans. It authorizes $15 million per year for the next 5 years for VA's maternity care programs, and it requires recommendations and annual public reporting on maternal health from the VA. Our veterans are not just our heroes. As moms, they're also the heroes of their families. During the vulnerable pregnancy and postpartum periods, they rely on us to ensure that they have access to high-quality maternity care. We owe them the best. I urge this committee to pass the Maternal Health for Veterans Act without delay and send it to the House floor this spring. Thank you so much for your time and consideration, and I yield back.
Thank you, Representative Underwood. The chair now recognizes Dr. Murphy for 3 minutes.
Thank you, Madam Chair, and I hope everybody was listening with what Representative Van Orden just said. It's quiet words, but extremely powerful. I have 3 Marine bases in my district of 21,000 military retirees, 50,000 active military family members. I'm honored today and fully believe in the bill I'm introducing today. I supported it since I came to Congress in 2019. I've worked on this same issue in North Carolina State House with really good results. I've been working for years, despite being a urologist, to help find treatments and procedures, et cetera, to help PTSD and TBI. This is an absolute criminal act by this country that we have increasing number of suicides despite statistical manipulation. The committee knows better than anybody else that a cure for PTSD and TBI is elusive. We must examine every treatment option that has potential to help our suffering veterans. H.R. 3649, the Veterans National Traumatic Brain Injury Act, requires the Department of VA to implement a 5-year pilot program to furnish, under the Veterans Community Care Program, hyperbaric oxygen therapy to veterans with traumatic brain injuries, TBI, or traumatic stress disorder, PTSD. I strongly recommend that we examine this issue. I'm happy to say that in the North Carolina House now, the legislature has funded many veterans to undergo this treatment, and I have seen personally, veterans who have been aided with this when literally they have hit the wall and nothing else has been available to them. I'm actually supportive of the hallucinogenics that Representative Van Orden was taking. This must be an all-hands-on-deck approach. Just a few weeks ago, I was at a large gala for this particular issue with Secretary Mike Pompeo. He is on board with this. 2021 report by the North Carolina Community Foundation of North Carolina East said to the legislature that there is an impressive number of successes through the HBOT program and treatments in North Carolina veterans. My bill is bipartisan. Don Davis, Marilyn Strickland, Representative Kiggins, Pappas, Duncan, Timmons, Bill Huizinga, Moylan are all co-sponsors, as well are multiple other VSOs. My intent is to offer another treatment. Reading the response to the VA in opposition, I'm very disappointed. It's an absolutely bureaucratic response. All hands on deck to stop this absolute scourge is what's happening with our veterans. I think the debate on risk is absolutely overstated. I have used this as a surgeon for close to 30 years, and yes, there are risks with any procedures. There are risks with an IV stick. But when it has come to the end of the road, at the end of the road, when our veterans have no other option, that they choose suicide, all hands on deck, whatever treatment we can as a veteran institution, Veterans Administration institution, is owed to our veterans. I ask for your support. Thank you. I yield back.
Thank you, Dr. Murphy. The chair now recognizes Representative LaLota for 3 minutes.
Thank you, Chairwoman Miller-Meeks, Ranking Member Brownlee, and members of the Veterans Health Committee for hosting this important hearing today and for allowing me to wave on. Vietnam veterans have a much greater chance of contracting, suffering from, and dying from the liver fluke parasite, and yet the VA doesn't cover their health-related coverage. The correlation between the liver fluke parasite and service in Vietnam is obvious. In fact, a first-of-its-kind study was conducted back in 2018 in the Northport VA Medical Center using a 50-veteran sample size. The initial results of that study highlighted 3 basic things: the substantial need for greater study of the issue, the development of standardized treatment options, and broader accessibility of care for veterans at VA facilities across the country. So the VA conducted another study, and after years of delays, that study recently found there was a 30% greater risk of mortality from this bile duct cancer for Marines who served in the Vietnam War as compared to Marines who served elsewhere, 30%. However, the VA still says that the study is not enough. And it's clear to me, a Navy veteran, and countless Vietnam veterans who have been suffering from and dying from the liver fluke parasite, that there should unequivocally be a designation of service connection for these veterans. And that is why I'm here today, Madam Chairwoman, to speak in favor of my legislation, H.R. 4224, the Liver Fluke Cancer Study Act, which would require the VA, in conjunction with the CDC, to conduct a study to determine the prevalence of liver fluke amongst the Vietnam veteran population. Madam Chairwoman, our Vietnam veterans are dying every day, and we do not have the luxury of time. Too much time has passed already, and we went through a similar terrible situation with our Blue Water Navy veterans and Agent Orange. Let's not make the same mistake twice. I urge all of my colleagues to support this legislation, and I want to thank the chairwoman and ranking member again for allowing me to testify in front of this committee, and I look forward to working with you and this entire committee to see this problem solved. Thank you, and I yield back.
Thank you. We also have two additional bills that we may hear about today, H.R. 3644, Act for Veterans Act by Representative Latta, and H.R. 5247, Expedited Hiring for VA-Trained Psychiatrists Act of 2023 by Representative Cartwright. They have both submitted statements for the record. As is our practice, we'll forego a round of questioning for the members. I now invite our first panel to the table. Thank you. Joining us today from the Department of Veterans Affairs is Dr. Ajit Pai, the Executive Director of the Office of Rehabilitation and Prosthetic Services at the Veterans Health Administration. Accompanying Dr. Pai today are Dr. Michael Brennan, Executive Director at the Office of Construction and Facilities Management, Veterans Affairs, Dr. Wendy Tinhula, Deputy Chief Research and Development Officer, Office of Research and Development, Veterans Health Administration, and Dr. David Perry, Chief Officer of Workforce Management and Consulting, Veterans Health Administration. Dr. Pai, you are now recognized for 5 minutes to present the department's testimony.
Good afternoon, Chairman Miller-Meeks, Ranking Member Brownlee, and members of the subcommittee. We are grateful for the opportunity to appear before you today to discuss this pending legislation. Joining me are Dr. Michael Brennan, Executive Director of the Office of Construction and Facilities Management, Dr. Wendy Tenhula, Deputy Chief of the Office of Research and Development, and Mr. David Perry, Chief Officer of Workforce Management and Consulting. VA supports several items of proposed legislation before us today. While VA's views on all of the bills are detailed in my written testimony, including areas of concern and support, I would like to highlight a few bills that would have profound effects on modernizing our delivery of services to veterans, their family members, and caregivers. First, VA supports to include with amendments H.R. 3303, the Maternal Health for Veterans Act, H.R. 3584, the Veterans Care Act, H.R. 5794, the VA Peer Neutrality Act of 2023, H.R. 6324, the FY 2024 VA Major Medical Facility Authorization Act. VA appreciates H.R. 3303 because it aligns with VA's current efforts to enhance the health outcomes of pregnant veterans. We note there is some ambiguity in the bill text, as it would require VA to provide data on the maternal health outcomes of veterans who receive medical care or services furnished by VA, when no VA medical facility furnishes maternity care. Although too prescriptive in its design, H.R. 3584 would authorize VA to conduct research in certain forms of cannabis on the health outcomes of veterans. I also want to thank the subcommittee for their efforts to improve the health outcomes of veterans through the introduction of several bills, including H.R. 4424, the Vietnam Veterans Liver Fluke Cancer Study Act, H.R. 5247, the Expedited Hiring of VA-Trained Psychiatrists Act of 2023, H.R. 7347, the Reporting on Determination to Include Newly Approved or Licensed Psychedelic Drugs in the VA Formulary Bill, and certain sections in H.R. 3225, the Build for Veterans Act of 2023. I want to emphasize that VA recognizes the congressional intent behind these bills, but many of the activities mandated are already being carried out or completed. For instance, with regards to HR 3225, VA is already identifying properties annually via the Disposal and Reuse Report, providing the total 10-year long-range action plan capital requirement and the major construction 5-year development plan requirements annually in the President's budget request, and incorporating recommendations from OIG, the Comptroller General, and others on how to detect and prevent waste, fraud, and abuse. With many reporting requirements and provisions in this bill, VA is best suited with extended deadlines and congressional acknowledgement of staffing needs and the availability of appropriations. Also, VA is currently conducting research to better understand the health risks and conditions of veterans who served in combat areas or were otherwise placed at higher risk due to their military service. An analysis of Vietnam-era veterans' deaths from 1979 to 2019 from cholangiocarcinoma is in its final stages of preparation for submission to a peer-reviewed scientific journal. VA fully supports the need to continue conducting research in this area. However, we believe the bill's requirements are already satisfied. Another example is that VA currently has the authority proposed in HR 5247 to initiate the appointment process for psychiatrists before they complete a residency. Lastly, VA would like to address our concerns with HR 3649, the Veterans National Traumatic Brain Injury Treatment Act, and HR 6373, the Veterans Stand Act. Regarding HR 3649, if enacted into law in its current form, the bill could have a negative impact on the lives of veterans. Extensive research conducted by VA, the Department of Defense, and others on the effectiveness of hyperbaric oxygen therapy, or HBOT, for traumatic brain injuries has shown no significant improvements, especially in cases of mild TBI. Studies comparing HBOT to a control intervention revealed that HBOT was linked to decreased quality of life during long-term follow-up at 2 and 3 years. Furthermore, aside from the lack of patient improvements, there's insufficient evidence to warrant the use of HBOT as a treatment for post-traumatic stress. We recognize that the advancement of assistive technology has significantly enhanced the lives of our nation's veterans. However, HR 6373, as currently written, could hinder VA's ability to safeguard veterans' well-being and undermine the integrity of the clinical decision-making process. Additionally, mandatory consultation with specific manufacturers or entities could create conflicts of interest that might jeopardize patient safety. VA providers collaborate closely with veterans to assess their needs and suggest the most suitable solutions. Exoskeletons, which can weigh up to 51 pounds, are complex medical devices. Clinicians trained in exoskeleton use consider various factors when prescribing this equipment. For safety reasons and due to the device complexity, the FDA mandates that individuals using this technology have a companion present. Unfortunately, many individuals do not have access to a suitable companion. We appreciate the congressional intent and welcome the opportunity to work closely with Congress on all of the bills on today's agenda. My colleagues and I are happy to respond to any questions you may have.
Thank you, Dr. Pai, for your testimony. I now yield myself 5 minutes. Typically, I go at the end, but today's an unusual day. Dr. Pai, the VA's TA included the request to initiate additional scientifically peer-reviewed clinical trials. Is the authority granted in the Veteran Care Act not broad enough to conduct multiple trials?
Thank you for the question. I'd like to defer to Dr. Tenhula.
Good afternoon. Thank you for the question and your interest in this issue. The bill as written, our concern is that it's too prescriptive in the framework that's laid out, and what we would request is to make several amendments and work with the committee staff on those.
You know, we deliberately tried to make it less prescriptive so that the VA could conduct and organize trials given their expertise in that rather than have that be directed from Congress, but would be happy to work with you in that endeavor. Dr. Pai, what coordination is necessary between the VA and other federal agencies to effectively conduct research under the Veteran Care Act? Or maybe Dr. Tenhula.
I'd be happy to take that question. What we would be interested in is working with other federal agencies in developing a plan for an observational study that would allow us to understand cannabis use among not only veterans, but a broader population, and not only veterans that seek care in the VA healthcare system. And so allowing us to work with other federal agencies on those efforts would allow for more unbiased data collection and would provide data that could inform those clinical trials that you mentioned and advise us in what direction to go with those trials.
Is there not already observation, so as a physician, is there not already observational data that's available,
There is not adequate observational data that's.
even from overseas?
I am not aware of the data from overseas. I would need to take that for the record and get more information.
And then either Dr. Pai or Dr. Tanhula, what effect will the Medical Marijuana and Cannabidiol Research Expansion Act have on Veterans Care Act and VA research into CBD and cannabis?
That act in particular, as I understand it, will not have direct impact on VA's ability to do this research. We already have the authorities in place that we need to be able to do the work.
Thank you very much. I now recognize Ranking Member Brownlee for any questions she may have.
Thank you, Madam Chair. My first question is to Dr. Pai. Thank you for being here. And I wanted to talk to you about H.R. 6373, the Veterans Stand Act. I'm frustrated that the VA opposes this bill. I suppose I can understand why you might be concerned about the provision that would require consultation with the manufacturers of assisted technologies and the potential conflict of interest this could raise. I think we could work with you on that. However, I'm confused as to why the department would oppose the rest of the bill to include codification of the annual preventive exams that VA should already be providing for veterans with spinal cord injuries and disorders. The VA also takes issue with the bill's definition of the term assistive technology. Could you elaborate on why VA has difficulty with our definition and how we could possibly amend the bill to address your concerns? Can we also at the end of the day, have your commitment to working together to get this bill on the right path and moving forward?
Thank you, ma'am. So to answer your second question about the definition of assistive technology, it's an overly broad term to be used. So assistive technology is not only for mobility devices and technologies for mobility devices, but also for speech and swallowing, communication. And so in this case, specific to this bill, it may be more appropriate to utilize assistive walking mobility or adaptive assistive mobility technologies, something very specific to mobility. With regards to your first concern or question about annual evaluations and codifying them, our VA's spinal cord injury and disorders system of care looks at the care for veterans with spinal cord injuries in a way that they're very committed to the comprehensive, lifelong care of those veterans from an evidence-based manner, using innovative and specialized care techniques. And for all veterans with spinal cord injury, they highly encourage those veterans to participate in annual evaluations. It's not a requirement of veterans because we want to make sure that we give veterans choice in their care, just as in anything else. And by codifying the annual evaluations, that can create challenges for those specific veterans.
Well, if we codified it, it must, in what you're saying, it must be causing problems right now, right? Because that's the policy and the directive.
For annual evaluations,
Yeah.
Correct.
Yeah.
So they are offered to all veterans with spinal cord injuries and disorders.
Right. Okay, very good. Mr. Perry, VA also opposes H.R. 5247, the Expedited Hiring for VA-Trained Psychiatrists Act. You said in your written testimony that it already has the authority to begin the appointment process for psychiatrists prior to completion of their residency. Could you please elaborate on this? What authority does VA currently use to directly hire psychiatry trainees, and to what extent can you also use this authority to directly hire physicians in order to, in other specialties who have trained at the VA?
Thank you, Representative Brownlee, for that question. Yes, we don't support this legislation because, as you stated, we have that authority now. So under Title 38, we have expedited hiring authority, which allows us up to a year to go ahead and proactively identify psychiatrists and other medical professionals that are in training and residency programs. And so we have the authorities now to do that under our current statute. So we really don't see any benefit for adding this additional legislation.
So can you share some data on how many clinical trainees convert to VA employment immediately upon completion of their residency?
I will tell you, not as many as we would like. We absolutely identified that the trainee pipeline is our biggest source and conduit that we should be pulling from. And so I don't have the exact number that we pull from each year, but we are aggressively targeting that pipeline for our trainees.
Can you give me a rough idea? Is it 10% or 20% or?
I think it varies by year. I don't think it's that high. I can tell you we train 70% of the residents that come through our VA institutions, but yes, we are not anywhere close to where we want to be in those targets, so we definitely have area of improvement. A lot of time our decisions around hiring are budget driven, and timing can be a factor as well, but we do like to target as advanced out as possible to hire these clinicians.
Okay, Dr. Brennan, I understand from your testimony that VA is undertaking the creation of facilities methodology, but you have concerns with meeting the timeline. Do you have a sense of when VA will be able to complete the staffing model?
Good afternoon, and thank you for that question. You know, if we're referring to Section 101 of the bill in particular, the current organizational structure in the VA includes staff who are responsible for all the functions that are set forth. One of the things we've done in parallel with probably the development of this bill has really been focusing on the strategy and integration of all the facilities, functions, and personnel that we have across the department to be better integrated to gain efficiencies. We're undergoing that right now. Along the same pathway, VHA is in the early stages of facility staffing methodology that will inform by standard performance metrics, and they believe it will require 450 days to develop a firm model.
How many days did you say? I didn't.
It may require more than the 450 days that are in the model.
Thank you. I yield back.
I spoke a little bit earlier about my disappointment in the VA's opposition to these and actually several of the other bills that we have in present. You know, I will be first to say that as a surgeon of now close to 35 years, I understand the complexities that occur with hyperbaric oxygen. I've dealt with it many, many times, and I understand the complexities here. But as Representative Van Orden said, point blank, we're failing our veterans. And I see an extremely bureaucratic response to this in opposition, as with some of these other bills, as to why it can't be done. So, Dr. Pai, I think this is your area of expertise. I'd love to hear your comments upon this so that we can have, you know, a respectful discussion in the opposition, probably.
Certainly. So, I completely agree with Representative Van Orden with regards to suicidality and the suicide being a problem, right? A major problem. It's our number one healthcare priority. And so with regards to hyperbaric oxygen therapy, it hasn't been shown to decrease suicide ideation. From a PTSD standpoint, it hasn't been shown to provide significant improvements. And what we're really focused on are those treatment options that do treat PTSD. Prolonged exposure, evidence-based or EMDR, as well as cognitive processing therapy. So we want to make sure that we're focused on treatments that are evidence-based for PTSD, and we are not diverting resources to interventions that are not proven for PTSD.
I'm going to respectfully disagree, because in the state of North Carolina now, where we're doing this, we are seeing tremendous results. We have a huge veteran community in eastern North Carolina, especially in Durham, North Carolina, in the center of the state and in the northeast corner, Dr. Moreno. They are seeing tremendous results with these. And, you know, again, we're going to get back to where this is literally the end of the road for individuals. I was very skeptical of psychedelics, read the literature, very proponent of this. I am not a fan of marijuana in a general sense, but I'm absolutely a fan if it's going to help our veterans, and it's very restricted. But I'm just saying, I'm reading in here, one of the things it might take, veterans may have to travel for this. Well, if the option is traveling to a cemetery and traveling to a VA to go get this therapy, by God, we ought to be knocking down the doors of hell to do it. It's critical. Yes, I understand that there is discussion about this, but we have several different avenues to choose from, and I am adamant, and I'm a scientist at heart, and I'm adamant that this makes the lives of individuals who are hitting the wall. And I think the Veterans Association Administration must pursue every single opportunity, because statistical manipulations and a decrease in suicides in this country is not acceptable to factually lowering that number. I would urge you, and it's going to maybe have to be in this committee's purview, to rethink this, to literally, as I said, all hands on deck for our veterans. When they're hitting the wall and they're committing suicide, we have to open up every door. Any other considerations? I will tell you, with Mr. Van Orden and Mr. Lolato's bills, I'm in full support of those things. I hate for us to be in adversarial role here. I think we have good individuals. I know your hearts are all in the right place, but it's our supervisory role to assist the VA, sometimes nudgingly, in what we're doing for our veterans. I thank you. It's the end of this subcommittee. I want to thank all testimony for hearing today. You are now excused and wait for the moment the second panel comes to the witness table. Did I do it right? I don't know.
I thought you were going to adjourn.
Thank you, all members. We'd like to start our second panel today. And our second panel, we have Mr. John Retzer, Assistant National Director for Disabled Veterans, Mr. Roscoe Butler, Senior Health Advisor at the Paralyzed Veterans of America, Ms. Brittany Elliott, Marine Corps veteran and advocate, and Ms. Melissa Bryant, Chair of the Directors of Boards of Minority Veterans of America. Mr. Retzer, you are now recognized for 5 minutes. Thank you.
Thank you, Chair Murphy, Ranking Member Brownlee, and members of the subcommittee. Thank you for inviting DAV to testify at this legislative hearing. We appreciate all the beneficial pieces of proposed legislation on agenda today that are focused on improving timely access and quality of services for our nation's veterans, in particular, service-disabled veterans. Throughout the past decade, the VA has experienced significant growth and difficulty implementing reforms that guarantee veterans receive access to quality health care. For VA to maintain its role as a primary provider of timely and quality care, it must address the challenge of an aging infrastructure by improving its internal capacity through the construction and modernization of facilities. Unfortunately, VA facilities have a median age of nearly 60 years, which poses a challenge with renovations. Facilities of this era were not designed to accommodate the technological and design innovation needs that support modern healthcare system. That is why DAV supports the bill for Veterans Act, H.R. 3225, which aims to enhance the VA's capital assets program by improving planning and oversight, providing more consistent funding, and strengthening capability to start and complete projects. Another key aspect of providing quality of care is safe and effective innovations and delivery of evidence-based treatments. The Veterans Care Act, H.R. 3584, would require the VA to conduct and support research on medicinal cannabis for treating veterans with PTSD, chronic pain, and other conditions. While many veterans are currently using cannabis, it is important for medical research to continue exploring the safety and efficacy of cannabis usage for medical purposes. Despite being able to talk about their cannabis use with VA clinicians, veterans cannot receive recommendations or prescriptions for cannabis from VA clinicians. Our nation's veterans deserve access to the most effective treatments and therapies available, including alternative options, which is why DAV supports H.R. 3584. Now to address the needs of the fastest growing cohorts of veterans using VA healthcare services. There are over 650,000 women veterans using VA, half of them being childbearing age. In fact, since 2014, VA has seen an 80% increase in maternity care services. Last month, DAV released our new report, Women Veterans, The Journey to Mental Wellness. It found that there can be an increased risk for mental health diagnosis and suicidality during pregnancy and up to 1 year after giving birth. The report emphasized the need for strong support systems and coordination during and after pregnancies. For these reasons, DAV strongly supports the Maternal Health for Veterans Act, H.R. 3303, which addresses the need to strengthen the VA oversight and expand funding to coordinate support and resources for women veteran mothers. To bolster VA mental health staffing to help reduce veteran suicide, DAV is pleased to support H.R. 5247, the Expedited Hiring for VA-Trained Psychiatrists Act. A 2023 VA Inspector General report revealed that more than half of VA's 139 medical facilities face a severe shortage of psychiatrists. The bill aims to reduce wait times for veterans seeking mental health care by allowing the VA to fast-track the hiring of psychiatrists who completed residency at VA facilities. Another bill DAV supports is H.R. 3644, the Act for Veterans Act, which would extend the time for veterans to notify VA after emergency care at non-VA facilities by an extra 24-hour period to ensure coverage under the Veterans Community Care Program. Currently, VA does not guarantee payment if a veteran does not contact the VA within 72 hours of receiving non-VA emergency care. Veterans suffering medical emergencies should not have to worry about whether VA will deny coverage or refuse payment because of administrative notification time requirements. Finally, for far too long, government reimbursement rates for emergency transportation have been significantly lower than the true cost of providing that service. Earlier this year, the VA finalized a proposed rule to change to cut its reimbursement rate for emergency air medical transportation. During health emergencies, this reduction could put an estimated 4.7 million veterans living in rural and remote communities who already struggle to get reliable access to health care at even greater risk. To address this concern, DAV supports H.R. 5530, the VA Emergency Transportation Access Act, which would limit the VA's ability to reduce payment rates for transporting veterans on specialized transportation modes. Chairman, this concludes my testimony. I am pleased to answer questions you or members of the subcommittee may have.
Thank you, Mr. Retzer. Mr. Butler, you are now recognized for 5 minutes.
Chairman, Ranking Member Brownlee, and members of the subcommittee, Paralyzed Veterans of America would like to thank you for this opportunity to present our views on some of the legislation that the subcommittee will be examining today. PVA strongly supports the BILL Act, which seeks to improve staffing to manage construction of VA assets and ensure that there are concrete plans to improve the planning, management, and budgeting of VA construction and capital asset programs. Among its many provisions, the Bill Act requires the VA to implement a more concrete schedule to eliminate or repurpose unused and vacant buildings, develop and execute a plan to hire construction personnel, examine infrastructure budgeting strategies, and identify required reforms, and provide annual budget requirements over a 10-year period. It also directs the VA to report to Congress on the department's current and future anticipated long-term care needs and models of care for women veterans, veterans with spinal cord injuries and disorders, and other veteran population with unique needs. This is particularly important of paralyzed veterans, as VA's current number of long-term care beds for veterans with SCID is woefully inadequate for an aging veteran population where care needs not readily met in the community. As of January, only 169 of VA's 181 SCID long-term care beds were actually available, and only one of VA's 6 specialized long-term care facilities lies west of the Mississippi River. Until construction projects at the Dallas and San Diego VA medical centers are completed, only 12 long-term care beds are available for the thousands of SCID veterans that reside in this area of the country. We urge Congress to pass this bill as soon as possible. PVA also supports the Expedited Hiring for VA-Trained Psychiatrists Act, which would help VA fill critical psychiatrist vacancies sooner. Many SCID centers lack the direct support of a psychiatrist, forcing the staff to submit intra and inter-facility consults for all veterans with SCID requiring psychiatric care. The response time to these consults are lengthy, delaying essential psychiatric care and services for these veterans. We believe the change authorized by this legislation could help veterans receive the essential psychiatric care they need sooner. Last year, VA announced a proposed final rule establishing a new payment methodology which would dramatically lower ground and air ambulance reimbursement rates. Part of the problem is that proposed rule relies on outdated data for air and ground transportation. PVA supports the VA Emergency Transportation Access Act because it would help ensure changes in reimbursement rates do not adversely impact veterans. Finally, we support the STAND Act, which would first ensure that veterans with SCIDs are offered an annual medical examination. These annual assessments are important because it allows the veteran's physician to identify and treat health issues before they worsen, review any changes that have occurred over the last year, and identify risk factors that could lead to future health problems and offer expert advice on how to mitigate them. Some VA facilities do an excellent job reaching out to SCID veterans to offer them an annual assessment, but not all, so there is room for improvement in this area. The bill also directs the VA to ensure veterans are assessed for and briefed on the types of assisted technologies that they may be eligible for during these annual exams. Advancement in technology could provide life-changing options for veterans with SCIDs, so it is extremely important that they are made aware of anything that could improve their mobility, functionality, or independence. Thank you again for this opportunity to share our views on some of the legislation being reviewed today. I would be happy to answer any questions you may have.
Thank you. Ms. Elliott, you're now recognized for 5 minutes.
Madam Chairwoman Miller Meeks, Ranking Member Brownlee, and distinguished members of this subcommittee. My name is Brittany Elliott, and I'm a medically retired U.S. Marine Corps veteran. I'm honored to join you today to discuss the critical importance of H.R. 6373, the VA Spinal Trauma Access to New Devices Act, or the STAND Act. I am joined here today by my father, full-time caregiver, and exoskeleton companion, Morgan Elliott. By way of background, I'm a medically eligible veteran in terms of VA healthcare, and I am fully paralyzed from my chest down as a result of a head-on collision with a drunk driver on July 3, 2015, and was placed in a wheelchair. Since you have my longer history in my written testimony, I'll skip forward to 2017 when I was introduced through social media and other means, not by the VA, to a device that I thought may have some utility for me if I were to ever regain the ability to stand and walk. The ReWalk personal-powered exoskeleton. I approached my care providers at the Memphis VA and started pushing to gain access to this technology. After significant hesitation by my local providers, I was finally able to get them to agree to enroll me in the VA's landmark study on the technology. The VA co-op study was being undertaken at several VA facilities across the country, but not in Memphis. So I was forced to travel on my own resources to the St. Louis VA Medical Center at Jefferson Barracks. I spent 3 weeks undergoing intensive training on the device. I might add, this is an 8-week process, but I am a Marine after all. And successfully completed this trial, at which point I was able to take the device home and start using it. I took it everywhere. Unfortunately, my story doesn't end there. When I returned to the St. Louis VA in 2018, my provider, the very same provider who entered me into the trial, informed me that she would not support my continued use of this device. And to this day, has prevailed to provide sufficient rationale for that decision. The device was returned to the VA, and I was left in a chair. I was also told you should get used to it because that's all you can expect. Well, as a trained warfighter, that's simply not good enough. For the next 4 years, that's right, a 4-year battle I was engaged with a battle, in a local and regional battle, to regain access to the device that had already so profoundly changed my life. Finally, and thanks to a forward-thinking and supportive clinician at the Sonny Montgomery VA Medical Center in Jackson, Mississippi, I was seen, reevaluated over the course of weeks, again on my own dime, and ultimately provided a new device, which I still have and use every day of my life. I am eternally grateful to this provider, as his disposition was not one that lent itself to the bureaucracy, but one that carefully considered the entirety of the evidence and the utility of this device for me, a young, vibrant, and motivated Marine. This fight never needed to happen, but the system in many cases, seems to me, is built to protect itself instead of the veterans it serves. I am so grateful to General Bergman for his authoring, and I want to personally thank Chairman Bost, Ranking Member Brownlee, and Congresswoman Dingell for their willingness to co-lead this effort. I would also personally like to thank Senators Tester and Moran for their companion bill that was introduced this morning. And my thanks as well to those who have agreed and continue to agree to co-sponsor the STAND Act. In my view, this bill is critical for a few reasons. As you all know, this bill seeks to codify what the VA is already supposed to be doing in the way of performing annual examinations. I can tell you with certainty they are not. I've had 5 exams over the last 8 years, and I had to push for several of those myself. Additionally, I think it's imperative that VA assess the viability of assistive technologies for all veterans with SCI, as simply forcing them to stay in chairs if they are clinically eligible for other devices is simply not good enough. The STAND Act mandates this type of assessment. One thing I've learned over my years of fighting the VA is that clinical behavior is often very difficult to change. One way to accomplish change, however, is to demand accountability for those responsible for making clinical decisions. This bill seeks to accomplish this by 2 means. Make the VA reportable to Congress on their success against the metrics I mentioned, and hold VIS and leadership accountable through their annual performance evaluations on these same metrics. In conclusion, Madam Chairwoman, Ranking Member Brownlee, and members of this subcommittee, I am very thankful to you and to all those who have supported this bill, as it can be truly life-changing for those like me, who have faithfully served their nation. But lack of system capacity, a widespread unwillingness of VA clinical leadership to allow veterans to enter the community for training, and just flat-out bureaucratic red tape continue to hamper other veterans' ability to gain access to these important technologies that can be truly life-changing. I can proudly stand in strong support of this bill, and I believe its impact can be truly immeasurable for those who are simply trying to rebuild their lives and who are seeking the VA support to get them there. With your collective help, this will be an easier path. I truly appreciate the opportunity to appear before you today, and I'm happy to respond to any question you may have.
Thank you, Ms. Elliott. Ms. Bryant, you're now recognized for 5 minutes.
Chairwoman Miller Meeks, Ranking Member Brownlee, distinguished members of the subcommittee, I'm Melissa Bryant, and I'm honored to appear before you today on behalf of Minority Veterans of America, where I serve as the chair of the board of directors. As an organization dedicated to advocating for the unique needs of minority veteran service members and their families, we appreciate the opportunity to provide testimony and to contribute the unique perspectives of those we serve to today's discussion. The focus of today's testimony will be on H.R. 3303, the Maternal Health for Veterans Act. MVA is dedicated to creating belonging and advancing equity and justice for our nation's historically marginalized and underserved veterans, racial and ethnic, gender, sexual, religious, and non-religious minorities. MVA works on behalf of more than 10.2 million minority veterans, and through our suite of programs, we directly serve thousands of veterans, service members, and their families each year. Of MVA members, 52% identify as women, 7% as gender diverse, 60% are traditional reproductive ages of 18 to 45, and 30% are survivors of military sexual trauma. As a former Army officer, I've witnessed firsthand the challenges of pregnancy for soldiers as they carry over for those soldiers when they become veterans, especially those who had to be administratively separated from active duty due to those challenges. We are grateful to be here today to represent their unique lived experiences and perspectives, stories highlighted within my written testimony of Des Lincoln, Khadijah Smith, Gracie Mongwell, and others. Maternal health for veterans is a critical aspect of care that addresses the unique needs of veterans who are navigating pregnancy, childbirth, and postpartum care. Veterans who use VA for care faced obstacles in accessing timely and appropriate maternal care due to the limited availability of on-site obstetric services and poor care coordination between VA and community-based providers. Those challenges are compounded by the unique health issues veterans face, including physical and mental health conditions resulting from their service, which can impact their pregnancy and birth experiences. Complexities such as traumatic brain injury or even musculoskeletal injuries, mental health conditions like PTS and depression, and even toxic exposures have been shown to have long-term consequences that impact reproductive health and pregnancy. The challenges minority veterans face are rooted in systemic inequities such as poverty, structural racism, implicit bias, and language and cultural barriers that impede access to essential prenatal labor, delivery, and postpartum care. And minority veterans often contend with higher rates of comorbidities like hypertension, diabetes, and mental health disorders, complicating their pregnancy and childbirth experiences and contributing to disparities in maternal health outcomes. These historical contexts and associated social determinants of health can significantly impact access and utilization of maternal health services within VA. And as Ms. Brownlee mentioned in her opening statement, GAO recently found that the severe maternal mortality rate was highest amongst Black veterans, highlighting pronounced disparities in maternal health outcomes. LGBTQ+ veterans also face additional hurdles in accessing maternal health services within the VA system, including harassment and systemic discrimination in care settings, in addition to disparate discharge statuses under policies like Don't Ask, Don't Tell, which impede VA access to care, or access to VA care, further exacerbating disparities in maternal health experiences and outcomes. The MCC program has served a pivotal role in enhancing access to comprehensive maternal care services, improving the care experience for pregnant and postpartum veterans, and addressing the unique healthcare needs of this population within the VA healthcare system. High utilization rates, its critical role in pregnancy care, a centralized telehealth program at the VISN level, and enhanced mental health support are among the key successes of the MCC program. But several areas for improvement remain, including remedying limited access to comprehensive maternity care, the lack of specialty care providers, fragmented care coordination, inadequate screening and risk assessment, limited mental health support, insufficient data collection and analysis, barriers to minority and rural veterans, and limited support for postpartum care. Issues unique to minority veterans include persistent racial inequities and insufficient training for LGBTQ+ support, requiring targeted interventions and outreach to address these disparities. MVA strongly supports H.R. 3303, recognizing its potential to significantly enhance maternity care coordination for veterans throughout pregnancy and 1 year postpartum within VA services. We urge Congress to strengthen this legislation by improving provisions specifically targeting the unique needs of minority veterans accessing maternal health services within the VA healthcare system. MVA also recommends enhancing cultural competency training, enhancing data collection analysis, strengthening community partnerships, improving language access services, and expanding access to doulas and culturally competent midwives, as doulas can provide care services that include offering emotional support to pregnant veterans through childbirth, and enhance their agency and self-advocacy, and have shown to mitigate preventative causes of maternal morbidity, as doulas can also uniquely provide trauma-informed care to our most vulnerable pregnant veterans. Addressing maternal health disparities among veterans is paramount for future generations who will return from service to start families. Again, we wholeheartedly support this bill. We thank you for the opportunity to testify today, and I look forward to any questions that you may have.
Thank you, Mr. Bryant, Ms. Bryant, and I'd like to thank all of our witnesses for their very thoughtful input. As is my practice, I'll recognize myself at the end of questionings. Ranking Member Brownlee, you are now recognized for 5 minutes.
Thank you, Madam Chair. My first question is to Ms. Bryant. In your testimony, you shared some very poignant stories from your members about their need for more support during and after their pregnancy, and certainly I'm excited about HR 3303, as I know you are, but I know that there is so much more that needs to be done to support our veterans who are pregnant or who have given birth. In your mind, is there a theme to the support needed in these stories that we should focus on to make sure these veterans get the support that they need?
Yes, Ranking Member Brownlee, I believe that the through line that was really identified and outlined throughout our testimony is that the wraparound services need to be there, and they need to be culturally competent, whether it's for someone who cannot access care because they need an interpreter, or whether it's someone who just needs that assistance and self-advocacy. We've now seen, we have data, we have the GAO report on top of VA's own data that show when you give those wraparound services, especially for those of us who are vulnerable, who are facing mental health challenges, that will mitigate very preventable issues that could happen when you are experiencing issues in accessing care within VA, and that can assist in your childbirth outcomes.
Very good. So what does wraparound services look like?
Wraparound services should address the social determinants of health. And so, as you saw from some of our member stories within our testimony, they're experiencing financial instability, they're experiencing housing insecurity. So those are the types of things that we should include within our wraparound services.
And they're all interconnected.
It's all inextricably linked.
Yeah. Thank you for that. And Ms. Elliott, it's very nice to have you here with us today, and I certainly want to applaud your father as your caregiver. I have a caregiver bill going through Congress right now, and hopefully we can bring more veterans to get their health care needs, disabled and aging veterans to get their health care in their homes, and to also provide help and support to the caregivers who are taking care of our nation's veterans. So wherever your father is, I applaud you. It's a challenging and rewarding job, but it's a job, I think, where sometimes the caregiver needs to have a little rest, himself or herself. So, but I really thank you, Ms. Elliott, for being here, and I was really looking forward to seeing you and your exoskeleton, because I have never seen it before. Alexis just showed me some pictures, so I sort of have an idea, but I was really looking forward to it. But I understand it got damaged by the airlines flying here.
It got damaged in transit, yes, ma'am. I was looking forward to presenting it today to you and to the rest of the subcommittee, but it was unfortunately damaged to a point that we could not utilize it today.
Yeah, that is really too bad. I also have a bill. I sit on the Transportation Committee, and I also have a bill to try to address this problem where so many people who have any kind of medical device, I'm sure they haven't seen many exoskeletons, but, you know, wheelchairs, motorized wheelchairs and so forth that get damaged too frequently on airplanes, and people are lost without their devices.
Yes, ma'am. I've personally also experienced those type of losses through an airline with my travel, so I do completely understand that.
Very good. So I think, you know, I think I'm happy that you're here to, you know, support the STAND Act. And can you just expand on why annual exams for veterans with spinal cord injuries are so crucial and actually need to be codified in this law? I mean, I'm sure you heard the VA testify that they wanted to make it a choice, but can you expand on that?
For me, that's the only way I can get, issues with my chair resolved or other unresolved health issues sometimes is through my annual exam. And those are crucially important in things like wheelchair maintenance, also just various health needs that the spinal cord injury and disease veterans face that are specific to our needs. Those are crucially important as part of longevity of life and ease of life. I mean, if my chair is broken for 6 months out of the year and I can't get into an appointment, that's a big inconvenience.
So, and you mentioned in your testimony too that you've had 5 out of 8 of your annual
Correct.
appointments. Did I understand that correctly? And that you said you had to really kind of push to get some of those appointments?
Yes, ma'am.
And so does that mean three times you were unsuccessful in getting your appointment?
Yes, ma'am. And it is not COVID's fault that I could not get all those appointments. I did have one virtual through COVID, so that was not the reason that I did not have all of the appointments that was necessary.
And so these annual appointments, when you leave an annual appointment, there's not the next annual appointment scheduled for you?
No, not usually.
I see that my time is up and the chair is anxious, and so I will yield my time back. Thank you.
Thank you very much, Ranking Member Brownlee. The chair now recognizes Representative Bergman for 5 minutes.
Thank you, Madam Chair. I want to first thank our witnesses from Paralyzed Veterans of America and Disabled American Veterans for being here today. Your presence makes a big difference. I know that you have worked with my office as we developed the Veterans Stand Act, and I was grateful to be able to discuss it with PVA President Thomas when he testified during our joint VSO hearing over at the Senate a few weeks ago. In that same vein, I'm going to take advantage of the opportunity to talk directly with Ms. Elliott while she's here today, in that same vein as I spoke with PVA President Thomas. So, Ms. Elliott, I am very familiar with your long-term struggle with dealing with the VA over your device. Given your role as an advocate and your routine interactions with the folks, the VA folks, can you share with the committee the experience of other veterans who are currently in similar circumstances? We've heard yours, but you got any other stories to share with us?
I actually do. Thank you for the question, Mr. Bergman. I've actually been working with a veteran as I also ski, and so I take my exoskeleton to the winter sports clinic, and I actually had a veteran personally reach out to me while I was walking my device, and he goes, "Can you help me?" And I said, what do you need help with, my friend? And he said, "I've been fighting the Richmond VA for years to get access to the rewalk, and I've only been given one option, and that's not that one. And I just need help. I need help with this bureaucratic tape that I'm facing." And I said, "I wish I could." I find that some of our veterans that I've worked very closely with are all fighting Richmond VA for that same access, but they're not the only VA. I've had veterans that come to me personally and say, "I've been fighting this war for years. Is there any advice that you have?" And I said, "Just don't give up. I'll fight any way that I can to help you, but it is going to be a war because they'd rather give you another chair than give you access to technologies that can truly change your life." So I stand by these guys. Most of them are young men, but I stand by these guys and offer support when they do get discouraged.
Thank you. Do you think there are others, or do you know personally of any others who may be clinically eligible already for the device but are simply being told no? Do you have any specifics there?
Yeah, actually, the one that was, he was clinically eligible for exoskeletons, but they're only giving him one option, and he doesn't feel that is the best option for his life. He intends to use it a whole lot more than just inside his house. And so veterans are acknowledging there's more than one technology available and want access to all the technologies, not just one that the VA specifically has decided to work beside for each VA center.
Okay. Do you think that the Veterans Administration's resistance to using this device is an issue of local medical center capacity, or who's passing the buck to who here? Any thoughts?
That's where the community care network would be crucial to veterans like myself. I traveled 10 hours to get access to the technology on my dime, and for most veterans, that's not possible. Can't give up that kind of time away from their families and their homes in order to get access to technology. But that's where our community care network would be crucially important in getting veteran access to the technologies and the training on closer to home, not having to travel hours upon hours away from home and family to get access to this technology.
You know, I think I saw a statement where the VA stated that the reporting requirements loaded on them will disallow them from doing their daily work with SCI veterans. So they are even currently meeting the mark in terms of the current workload. There's kind of a workload balance here, claiming they got too much so they can't do this or that. If not, are there any professional resources centers available in the community, because you referenced community care, that could be used to train veterans on this device? So, you know, different entities?
So even I personally trained with a community care provider in my own community post-injury because it was so inconvenient for me to go to outpatient VA. So any outpatient VA center or outpatient community care provider who has already been deemed eligible to get community care services for veterans would be eligible to teach veterans how to use this technology.
Okay. And I see my time is just about up. I'm not putting words in the mouth of the Secretary McDonough, but when we traveled up in the Upper Peninsula of Michigan together in December, and he spoke to our VA hospital, a couple of clinics, he made it very clear that whatever the Veterans Administration did, the veterans should not have to wait because the bureaucracy was doing its thing and not prioritizing the veteran. That was his intent, and Secretary McDonough is a man of his word, and he knows, and he's got his hands full just like we have hands full. So thank you for the indulgence, Madam Chair.
You're welcome. Thank you very much. I now recognize myself for 5 minutes. It's interesting listening to all of your testimony, and I'm going to deviate from my questions. I'll ask one of the questions I plan to ask, but then I'm going to deviate. Mr. Butler, Mr. Retzer, can you share what you've heard from your members about their experiences with therapeutic medicinal use of cannabis or cannabis-derived products?
We haven't really received any information from our members directly about the product. We are interested in seeing the research go forward and the evidence that it provides efficacy to meet the clinical needs of veterans so that they can sustain their lives more. So we're hopeful that the evidence will prove that it has efficacy in the support of clinical needs for the veterans.
Mr. Retzer?
Thank you for that question. Our membership actually has a resolution, as a resolution-based organization, where we call for the research of medical efficacy of cannabis for service-connected disabled veterans. So it's very important to us. And we have also published multiple articles with regards to the cannabis studies and the innovations in the direction for needs for options for our veterans.
I hear similar things from the veterans in my community as well. And Ms. Bryant, this is not necessarily a question. While I'm not opposed to Representative Underwood's bill, it seems like we have a tremendous amount of data, both with veterans and non-veterans. As a physician and former director of public health, this is not an area that's unfamiliar to me. It also seems like we have recommendations for how to reduce maternal morbidity and mortality. Do we really need another report to Congress, or is it better that we utilize the money to implement practices and evidence-based practices that we feel will be effective?
In order to address the epidemic, as you stated, Chairwoman, that we are facing in this country, we have to have that information from VA as the representative of the largest integrated healthcare system in our country to contribute to the whole within our healthcare system. Having regularly reported data being able to see the intersectionality and the impact of intersectionality within maternal health care will be a boon for the rest of the entire industry and being able to address a lot of the issues that veterans face and all women face.
Thank you. And then where I'm going to deviate is this. So, Ms. Elliott, I started my career in the military. I did medical surgical nursing, and I did emergency room nursing, and then I got assigned to Walter Reed Army Medical Center as a young lieutenant, and I was assigned to neurosurgery at Ward 10 at Walter Reed. We did traumatic brain injuries, which were not caused that at the time. I flipped many of a striker frame. Both my husband and I did care after our time, so this is taking me back to my very early days as a nurse, although I did not do neurosurgery as a physician. It is appalling to me that you were told to just get used to it. The VA is probably one of the premier institutions for prosthetic devices, and why we do not consider an exoskeleton or other devices to help our veterans become ambulatory, become independent, is hard for me to fathom. I'm going to look at this as a physician, and what are the consequences of being in a wheelchair when you could be somewhat ambulatory or upright? And I apologize for those of you who are not medical, because some of this is rather, I don't consider it gross, but pressure sores, debridement of pressure sores, the cost of hospitalization, the cost of being bedridden, the cost of urinary tract infections, catheterization, the cost of impaction, all of those, and then not to count what it does to the veterans' individual mental health and that of their families when they could be productive and have active, engaged minds. And I still visit and take care of people who have spinal cord injuries in the civilian world as well. Thank you for mentioning the Community Care Network and how crucially necessary it is. And to me, given the VA's track record on prosthetic devices and helping our military and veterans be whole, it is unfortunate that we would have to consider legislation for the VA to bring veterans back to a livelihood, a production, care for their families, interactions in their communities. So I know I'm pontificating, but I cannot thank you enough for being here today and for your testimony.
Thank you, Madam Chairwoman.
With that, that concludes our second panel. Ranking Member Brownlee, would you like to make any closing remarks?
I don't, but I just want to thank the panelists who are here today, and I think we've got a lot of good bills here that I hope we can move along and move over to the Senate.
On behalf of the committee, I'd extend my thanks to all of the witnesses today. I look forward to working with the stakeholders, my colleagues, the Department of Veterans Affairs, to address the issues we discussed today. The complete written statements of today's witnesses will be entered into the hearing record. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and to include extraneous material. Hearing no objections, so ordered. I thank the members and the witnesses for their attendance and participation today. This hearing is now adjourned.